Okay. Hello, everyone. Welcome to Hot Seat again.
Definitely.
I'm Omid Moghaddas joining you from Tehran. And I'm so happy to have the chance to share with you the latest updates in implant dentistry with great speakers from around the world, great educators that I'm so proud and honored that they accepted the invitation and are joining us in this series of Hot Seat in the year of 2020, which is a pandemic situation. And we are not really able to go around the world and join symposiums and congresses. And as you all know, over the past sessions, we talked about almost all aspects in surgical field of implant dentistry, in prosthetics and aesthetics complications. But what was missed here a little bit was about the loading protocols and how we should decide when to load our implant and what are the criteria available that make it more predictable in our treatment planning. And I have to say, I'm super honored that a very dear friend, uh, Professor Christian Makary, I'm so honored to call him my friend, has joined me in the hot seat today. And I'm pretty sure all of you know this gentleman, and he's a true educator. I remember back in maybe 10 years ago when I started my practice at the very early years, I saw his work and presentations on one of the ICOI meetings in Tehran, and that was it. So I went there and said, "Hi, Christian, I'm a great fan." I don't know if you remember, it was in Azadi Hotel in Tehran. So before going to the details, welcome, Christian, to Hot
Yes,
Seat.
of course.
I'm so happy to have you here, my friend.
Thank you, Omid. It's always great. You're a dear friend. We've met many times in Tehran for sure, but also in congresses all over the world. I had the chance to be part of your congress. I kept for you. You can see your
Yes,
statue there from the. I have it in my office. So it's a great pleasure to be with you tonight. I hope we could be together in Tehran, but through the hot seat that you're doing I think it's a great opportunity to be able to share our know-how, the lecture with colleagues all over the world. So I'm
thank you. Thank you so much, my friend. The pleasure is mine, and thank you for joining. And as you said, we had a chance to have you as one of our keynote speakers at the Symposium of Complications, and really hope to have you soon again. And the topic that Christian going to talk about for us today is about from planning to loading, the keys for a successful implant treatment. And before we start, I would like to have Dr. Christian Makary's CV for all of you, and then we will go to the presentation, and at the end we will have a discussion on the topic. Dr. Makary was born in Lebanon in 1969. He graduated as a doctor of dental surgery in 1993 from the St. Joseph University of Beirut in Lebanon. He holds a certificate of oral surgery from Paris 7 University, a university diploma in oral implantology from Bordeaux Second University, and a university diploma in oral pathology from Paris 6 University in France. He also holds a Master in Science and PhD in Oral Biology from St. Joseph University of Beirut in Lebanon. He was the former chairperson and is currently an associate professor and the director of postgraduate program at the Oral Surgery Department of the Faculty of Dental Medicine of the St. Joseph University of Beirut in Lebanon. He's a diplomate of ICOI and ICOI ambassador and international vice president of ICOI in Lebanon, an active member of the International Piezosurgery Network, IPN, and of the International Piezoelectric Surgery Academy, IPA. His professional practice is limited since 1996 to oral surgery and oral implantology, and has lectured on oral implantology in numerous local and international congresses, mainly on the topic of sinus grafting, extraction site management, and ultrasonic implant site preparation. He has several publications in the field of oral surgery and oral implantology. And I have to say, the way that Professor Makary presents, the details that he will show you, and the type of photography, for me, is the toppest. So I'm so happy. I'm pretty sure you will enjoy every second of his presentation, and it's a great chance to have this opportunity in this hour to join his great magic and science. So with that said, I will shorten my speech, and Christian, we are ready for your beautiful presentation, my friend.
Thank you. Thank you. Thank you, Omid. It's a great pleasure. So let me share my screen. It's there. You can see the screen.
Perfect. Perfect.
Okay. So as you said, I'll be talking today about loading protocols. The idea behind this lecture is to say that loading protocols cannot be done out of randomly. It should be based on a clinical, on a scientific rationale. And this is what we are going to discuss today during this 45 minutes. This is our university in Beirut. I hope that one day, Omid, you can visit us there, and I hope some of the colleagues that are following us can come and visit us. It's an opportunity for me to acknowledge all of the faculty, the postgrad students at the oral surgery department with whom I've been working over the last years, and the studies, the clinical studies that I will be showing or referring to today were done with their support and with their help. So what do we know about loading protocols? Loading protocols started, the strategy in the 80s was totally different. We used to go for 6 months healing in the maxilla, 4 months healing in the mandible, which means that sometimes it took up to 7 months to load our implants. And then this process started to evolve with the evolution of implant designs, of implant microgeometry, mainly surface treatment, and it went going from 6 months to 4 months, 3 months, until we reached the milestone of 6 weeks loading. That is today one of the most accepted protocols, mainly when we have an implant with a good surface, mainly when we have enough bone. But if we want to go further with our loading protocol, we can start doing the early 4-week loading protocol and the immediate loading protocol. And what I will focus on today is these two categories, which are early loading. And when we talk about early loading protocol today, we talk about 4 weeks loading and immediate loading protocol. And what we need to answer is, what are the rules? What are the prerequisites to be able today to decide if we want to do a 4-week loading protocol? Can we do it in each case that we have? Are there some contraindication? What are the indications? And what is the clinical and scientific rationale about this? So we know today that when we started drilling and placing our implant, there is the first feeling that we have between that implant and the bone. And this is what we can feel through insertion torque levels, through primary stability. And this is when we start our osseointegration protocol. And this is what we call secondary stability, that will start the moment that implant goes inside the bone, the moment blood will come over the implant surface and cells will start to form and create new bone over the surface. So what's the importance of insertion torque and primary stability if we want to do implant loading? What's the importance of secondary stability? This is what I will try to go through during this 45 minutes. We know that insertion torque is that force that you need in order to screw an implant inside the bone. Some people will always try to be confused between insertion torque and primary stability, but these are two different ways of measuring stability of implant. So insertion torque is the force needed to screw an implant inside the bone. Primary stability is the force needed to, or the micromotion that one implant has when it is it undergoes loading or it undergoes some lateral forces inside the bone. It can have a micromotion. This micromotion can alter osseointegration if it comes early on that implant, depending on the degree of primary stability that we have. How can we measure primary stability? Because this is something that we cannot see, is by using this Ostel machine. There are, of course, other techniques that can be used, but the most recognized scientific machine or method to measure primary stability today is Ostel ISQ. And we will have values that can tell us if our implant is in the low stability zone, this is the red zone that you can see on this slide, or in the medium stability, or in the high stability zone, and this is the green part that you see on the slide. And when we are in the high stability zone, this is when we can be more confident to do immediate or early loading protocols. Then we have the secondary stability that is most commonly also recognized as osseointegration. This is, as I said, when your implant will be placed inside the bone. This is when the biological process will come to take over the primary stability. And if you look into these histologic images from Berglund and co-workers study, it's a wonderful study that they did on dogs. And you see at the left, we have an implant that is holding mechanically. You see that the threads of the implant are holding this implant inside the bone. And this is if you want the baseline primary stability or mechanical stability. And on the right, you see an implant where bone turnover happened, where bone was formed around the threads. And this is what we call the osseointegration process. And this is when we start talking about secondary stability. This is the famous Raghavendra curve. And I'm sure that most of you are familiar with this curve. This curve shows you two measures. It measures the primary stability, the mechanical stability that is in a black line. And you know that this mechanical stability will go into a dip because bone is elastic, because bone will remodel, will resorb over the first weeks. And you see that there is the dashed line that represents secondary stability, and this is new bone formation around this implant. So after 5 to 6 weeks, when osseointegration occurs, when biological stability occurs, we don't have anymore this fear of having a loss of our implant, but this is the critical period. The critical period is between 2 and 4 weeks. So if we load our implant and we have a bad curve, and we have a bad surface, or we have a loss of primary stability, we will talk about this later on during this lecture. This is when we are in the danger zone, and this is what we don't need to have if we want to do immediate or early loading protocols. So there are a lot of factors that can determine insertion torque, primary stability, and secondary stability. We will discuss 3 that are bone density, implant site preparation technique, and implant geometry. Bone density, it's very important to know what kind of bone you're dealing with. If you have a patient with that type of bone, where the bone is very cortical, it's very hard, of course, in these cases, you can have a very high insertion torque, a very high implant stability. But is it good for the biology? We will discuss later on. We know today that we have 4 types of bones, type 1, 2, 3, and 4. This is the most common classification for bone types. There are a lot of other classifications. We will not go into all the details because we don't have enough time to discuss everything today. And we know that this is part of a publication that we did a few years ago, where we did histologies, and we could determine the different types of bone in different types of maxilla and mandible. And you see that the histology on the right, the D1 bone is a very mineral bone, and the D4 bone that is on the left is a very soft bone. And you see that you have very low amount of mineral substance inside this histology. And how this can be clinically assessed, because you cannot always do a histology. It's either by doing what we call the clinical perception on drilling, that was described by Mish in 1999, where he tried to give an idea of the bone hardness by making similarity between bone and wood. And you see that when the bone is like very hard wood, you talk about a D1, and when it's very soft, you talk about a D4. So this is an easy way to determine while drilling what kind of bone you can expect. Today, there are a lot of new softwares like this R2Gate software that you can download for free, for instance, that can give you valuable information where you can plan, you can do the choice of implant, and you can decide on your loading protocol based on the type of bone that you can expect when you start drilling inside. You don't need to be surprised. You don't need to give hopes to your patient, telling him that you can do an immediate loading case, and once you start drilling, you find that the bone is very soft, you have a very bad primary stability, then if you load, you're taking a high risk. So there is a whole scenario that you should be planning before doing your loading, and this is why it's very important from planning to loading to control all the keys to have a successful implant case. So today, if you want to place this implant inside the bone, you have to be almost certain that you can have a proper stability if you promise this implant or this patient an immediate or an early loading protocol. We know also that bone can affect insertion torque. If you look at this, the result of this study that we published, you see that when we are in hard bone, we have a mean value of 120 Newton, which is very high, and in soft bone, it can go all the way till 15 Newton centimeter, which is very low. So once we assess bone, once we try to control this variable, we have to think about the implant site preparation technique that we use. And we know today that we have 3 different types of implant site preparation techniques. The normal drilling, this is the technique that we almost use in every day's practice, the ultrasonic implant site preparation, and the osteotomes. Osteotomes can compact bone. Osteotomes can give us some more compaction of the bone, especially when the bone is soft. It can give us better result if we follow this study, and I cited this study for you, Omid, because this is Iranian authors. The problem with osteotome is that I don't like to crash bone, and I'll tell you why, because it can delay bone healing around an implant. Ultrasonic implant site preparation, we've done some clinical histological study on this technology. It's a very nice and secure way to prepare the bone. But what is more important is that by using this technology, there are studies that show that we can enhance bone healing around the implant, and we can help our osseointegration happen faster, so we can reduce that dip that I showed you in the Raghavendra curve at the beginning of the lecture. But this is not part of our lecture today. I just mentioned it. It's a whole process that needs maybe for a whole lecture to discuss only ultrasonic implant site preparation. What counts today is drilling, because this is what we almost use in 99% of the cases, unless you are a fan of piezosurgery as I am, but mainly majority of surgeons will use drilling. And when we use drilling and you want to enhance primary stability, the easiest way to do is to under-drill the implant size. By under-drilling, by undersizing implant bed, you will have a smaller preparation inside the bone, and then by squeezing in the implant inside the bone, it's the easiest way to have a higher insertion torque. And as you can see in the graph here, when we undersize, we have higher insertion torque, we have higher stability. But if this is good at day 0, if we look in the histologies in this very nice publication by Coelho and co-workers, you see that when we squeeze the bone, we have some bone remodeling. We have some necrosis that is happening because this bone is being crashed by the implant, because the geometry of the implant does not fit the implant bed that we prepare. This is why we have a lot of pressure that may induce some remodeling. And we will see later on how this remodeling may be bad for our early loading protocol. Of course, I'm not saying that an implant like this will fail. I'm saying that in the first 4 weeks, this might affect the stability of the implant. And maybe the third and most important factor that can affect our future loading protocol is implant geometry. And we see that we have a lot of variability when we talk about implant macrogeometry and implant microgeometry. For only one implant company, look how many implant designs we have. So today, as clinicians, we have to face the decision to choose the proper implant geometry, the ideal implant geometry. We know for a fact that when we use cylindrical implant versus tapered implant, we will have a higher stability, and this is something that is very well recognized. And you see at this graph on the left that we had almost double or 3 times more stability or insertion torque values when we used tapered implant compared to cylindrical implants. Also, if you talk about surface microtopography, this is the microgeometry of the implant. We know also, and this is a fact, that there are some surfaces that can give you better result than other surfaces. In this study, they compared RBM surface to X-speed surface, and you see the X-speed surface, that is a nano surface, gave a better result in early loading than the other. If you compare it with machine surface, for instance, you will even have a huge difference between these surfaces. And it's important to know that if a surface is bad, you will have a delayed healing over the surface, and this also will affect the early osseointegration, and by that it will affect early loading. So we know that if we use that same implant geometry but with 2 different surfaces, we may have 2 different responses of the bone. So microtopography is very important. If you want to do early loading, if you want to do immediate loading, you need to have an implant also with a good surface treatment. This study is very important because it compares 2 implants from one same implant company. So there is no bias between 2 companies. And you see that the implant to the left is an implant with a V thread, a normal thread that you will find on a lot of implants. And the implant to the right is an implant with a knife thread. It's a very thin, sharp thread that goes and cuts the bone. And if we try to analyze before seeing the result, I would tell you that the implant on the left will crash a little bit the bone, while the implant on the right will cut into the bone. And if we try to see how this is shown in the stability of the implant, look at the graph. The blue implant is the one with knife thin threads, and you see that for this implant, the curve of stability did not go down, it kept going up, and it stabilized, because obviously this implant did not harm the bone, we did not have any remodeling of the bone, while the implant in orange, you see that the stability went down over the weeks, and I'm sure if we continue, it will go up again. But what counts is that in this early period, we had an implant that did not lose stability and an implant that lost stability. I'm not saying that the orange implant will fail. I'm just saying that the blue implant is more likely to be used if you want to do early or immediate loading protocols. So today, what are the rules and the requirements if you want to do decide on early loading protocol or immediate loading protocol? The first thing is to be able to have an implant that gives you a high insertion torque without harming the bone. We've seen that when we squeeze an implant inside, or when we use the wrong geometry, we can have pressure over the bone that may lead to remodeling. Sometimes it may lead to failure. We'll discuss it later on. We need an implant that can give us an optimal stability regardless of bone type, because if I want to do an implant early loading, I need to do it in soft bone and in hard bone. And if sometimes it's easy to do it in bone, it's much more difficult to do it in soft bone. And I need an implant that has a good microtopography that can give us a dynamic healing and a fast osseointegration. And of course, I need that all this be stable over the first critical 6 weeks after implant placement. I share with you the result of a clinical study that we performed at the St. Joseph University at the oral surgery department, where we tested an implant. It's a particular implant that has a versatile geometry that can be adapted to bone type. It's the Eneridge implant from Megagen. And you see that this implant had a core diameter that is always the same. Like in these 4 implants is 3.3 millimeter. And what is changing is the diameter of the threads. And depending if we are using this implant in hard bone or in soft bone, we may opt for an implant with small threads or with large and deep threads. So it's the same drilling protocol. You drill until you reach 3.3 millimeter. That is the exact dimension of the core of the implant. So the core of the implant will not give any pressure on the bone, and you just go and have the stability by the threads. So you drill to 3.3, we place the implant, and look how the threads are going out inside the bone to give us the stability. And if these threads are very thin and very cutting, you will not have pressure or crushing of the bone. It will cut inside the bone and give you the stability that you need. And this is very important because it will help us maintain the stability because of a very low bone remodeling afterward. So you see some cases when we have very hard bone on the left, we use an implant with small threads, and when we have very soft bone on the right, we use an implant with large threads. And you could understand here that if I have one implant geometry that I want to use in very hard bone and in very soft bone, I will definitely have very high insertion torque in hard bone and soft, and very low insertion torque in soft bone. The only way to be able to control bone density is to be able to change my implant geometry and adapt it to the bone type that I have. So let's see how we behaved in this study. So what we did, like this is a case, a normal posterior maxillary case. We know that in the posterior maxilla, the bone is usually from a medium quality. It's around D2 or D3. Most often it's D3 or D4, even if you go back in the molar area I'm drilling now. And if we have a bone that is soft, we can expect to have a so-so insertion torque and primary stability. And this is why you cannot promise your patient when you are in the posterior maxilla, you cannot always promise to do immediate or early loading protocol, because you're not sure that you can have a very good stability for your implant. And if you don't have enough stability, we prefer to go to wait 6-8 weeks and then do a normal loading protocol where we can secure that we have enough bone healing and stability around our implant before we start loading. So we see that here, while I'm drilling, I can assess the bone type, and based on the bone type that I assess, I choose the implant geometry, and you see that this implant has very thin threads, and these thin threads are deep, and they will go and catch the bone to give us the stability that we need. I'll go a little bit faster. So once we placed our implant, in the same time we measured the insertion torque. We had a special tool to measure insertion torque because this was done for clinical study purposes. You see that now I'm using an electronic torque wrench in order to measure my insertion torque. And then I measured primary stability. To do so, we use this smart pack. This is the smart packs from Ostel. And every implant has a different smart pack that is adapted to the connection. And you see that now we measure these ISQ values that I showed you at the beginning to be able to see if these implants can be loaded or cannot be loaded, and to monitor ISQ values over the 4 weeks. So this was done to measure ISQ day 0. Then we put some healing abutment, and this is the result that we got for these 2 implants. See that I had an IT value that is 69 Newton for the implant, the anterior, and 48 Newton the implant, the posterior. And if you are familiar with IT values and with placing implant the posterior maxilla, you could tell that these values are very good values when we are in the posterior maxilla. So if we look into the whole results that we had, you see that what I've got in my study was a insertion torque that was lower than other studies in the hard bone, because in the hard bone I don't need very hard insertion torque, but I am at 100 Newton, which is almost very hard, and elevated results in the soft bone. Usually we are between 20 and 30. Now we are at 60 with an optimal result of 81 Newton. If I compare it with some studies that we did in our group, you see that we have lower insertion torque values in hard bone and higher insertion torque values in soft bone, and this is what I need to have. I need to try to converge towards an optimal value that is between 50 and 80. And if we look into these values, we see that most of my implants were placed around this optimal value that is 80 in this case. And this is when I am in a comfort zone where I can place my implant with very good stability without harming the bone. The danger zone, if you want to do immediate loading or 4 weeks early loading, is to be below 30 Newton centimeter. None of my implants were in this zone. If I compare it with other studies that we did, you see that there was a lot of implants that were in the danger zone that were below 20 Newton centimeter. Some implants were around 50 Newton centimeter in soft bone. So these implants, for instance, cannot be immediately loaded, or if you do it, you're taking some risk that you don't need to do for your patient. ISQ values. you see ISQ values in different bone types, and in all bone types, they were above 70. But what is the threshold? What does these values mean for you? There is one thing that you should see, that we did not have a dip in the ISQ value, which means that we had stability over time, which means that this stability was not harmed by a lot of remodeling. This means that we did not have resorption of the bone after we placed our implant. But if we compare it to these values from Oster company based on the literature, you see that we have three zones. The low stability zone, and we have none of our implants were there. The medium stability zone, also all of our implants were not there. And the high stability zone, and you see that all of the implants that were tested in this study were above the high stability, were inside the high stability zone, so there were candidates for immediate and early loading protocol. And this is not the same if you compare with other studies. I compare with our studies, not to compare with other authors, and you see that in our studies at 0, at 3 weeks, at 6 weeks, we always had implants that were in the medium and low stability zone, and these implants were not always good candidates for immediate and early loading protocol. So this is very important to always have stable results. The second thing, the third thing that you need to know is the secondary healing results, and this can be measured by ISQ over time, but also by histology. And this is the new study that we are undergoing in order to be able to measure secondary stability. We are doing a histological study, human histology. The results are coming in. I hope that in the coming months we'll be able to share these results with you, but you see that we have very encouraging results. At 4 weeks, we have in this cut 99% of bone to implant contact on an X-speed surface, which is huge. Of course, not all of these implants are the same, even in this group, but to say that we have a very good result at 4 weeks, very good result at 6 weeks that you see at right, and this is very important if you want to have ease of mind when you place your implant. So if you come back to this curve, this famous curve, you see that by using the proper implant, we could flatten the curve. We avoid having a deepening, a dip into the curve that may affect the first 4 to 5 weeks our implant success rate if we use early or immediate loading protocols. Survival rate for our group was 100%. All our 40 implants were loaded at 4 weeks successfully. We did not have any failures. The marginal bone loss at 12 months was 0.18 millimeter, which is very good because the connection also is very good if we don't have any bone loss. Look at some of the cases at 1 year post-operatively. All of these cases were loaded at 4 weeks. This is another case in the maxilla, and you can see the geometry of the implant in the maxilla because I needed to have an implant with deep thread to be able to have very good stability. And look at the result for an implant that was loaded at 4 weeks in the posterior maxilla. So if we come back to these insertion torque values, we see that we have some insertion torque values that were above 100 Newton. Is it safe to go that high? If we look into some of the implants, these are implants that I placed in the posterior mandible where the bone was very hard. This is a very good implant. I'm not criticizing the implant. I placed it with very high insertion torque, and look what happened after 6 weeks of healing. After 6 weeks of healing, you see that the bone necroded all over this implant. Why did this happen? Because this implant geometry was not created to withstand high insertion torque. It's not that that implant is good or bad. I say again, this is a very good implant company. They have a very good surface, but these implants were not created to be placed with high insertion torque, which means that if you cannot place an implant with a high insertion torque, you cannot have enough stability to do immediate loading or early loading. So these implants are fine if you place them with low insertion torque, let them heal for 6 weeks and then load them again, they will give very good results. These are other implant geometry that can give you a loss of bone because of high insertion torque at 6 weeks, at 8 weeks. So yes, this phenomenon happened. This is one of the implants that was part of our study. And when we placed this implant, the bone was very hard. And while we went inside the bone, we had a very high insertion torque that was 186 Newton. This is huge. This is the maximum that maybe you can get before the implant color will be damaged. ISQ values of 83. You remember that 70 was the threshold. We have 83, which is also very huge. So when I placed this implant, And you know that when you place an implant and it's stuck inside the bone, you cannot remove it, you have to keep inserting it. I was almost sure that I will lose bone around this implant because of this pressure, because of the necrosis that will happen. I was going to lose some bone around this implant. But when I came back and I looked at this implant 3 months later, look at the healing, 0 bone loss. The bone was very nice around the implant. 18 months, everything is stable. And why did this happen? This happened because this implant geometry, particular implant geometry, was created in a way that it fits the implant site preparation and it can withstand high insertion torque without giving a lot of pressure, negative pressure around the bone that can lead to remodeling and necrosis. So if we can again to this graph, you see that when we use particular implant geometries, when we use adapted implant site preparation technique, we can accept to have implant placed with high insertion torque. Of course, my message is not to place implant with 140 Newton centimeter. My message is to keep your implant inside an optimal zone that is around 60 to 80 Newton centimeter. And you see that most of the implant in our study were inside this zone, because this is where you have ease of mind. You know that you have very good mechanical stability. You can load your implant. You will not lose a lot of your stability over the weeks because no or very minimal remodeling is seen, and you know that you have a good surface that will take over very quickly, so you will have a good osseointegration. So what are the clinical applications? It's this kind of implants can be used if you want to do early loading in a predictable way, immediate implant placement because you have some good stability and you want to do immediate temporization, and immediate loading, of course. Today, the standard of care for our patients is to do 4 weeks loading in the mandible, in the maxilla, to adapt the implant geometry to the bone density that we have. This is very important in order to be able to have enough stability. We measure the ISQ. If our ISQ is in the comfort zone, we go on, we place our healing abutment. 4 weeks later, we do our loading, and we have a very nice loading at 4 weeks with a result that are stable over time, and this is the result at 1 year. So yes, every time that we can adapt our implant anatomy to bone density and that we can have predictable stability, we do a 4-week early loading. This is a case that is very interesting to analyze. And I like this case because it shows how implant geometry in hard bone can lead to loss of bone and loss of implant and failures. So in this case, I placed these implants. These are also very good implants, but maybe that they were not fit to withstand high insertion torque and high bone. And you see that it started, the phenomenon started immediately. During healing, I started to lose bone around these implants. And when I loaded these implants, this phenomenon went on because now the implant surface that was uncovered was we had the peri-implantitis, and this peri-implantitis evolved over time. And you see that because of a bad implant placement, because of a bad reaction of the bone around the implant that we could avoid by either over drilling the site or by countersinking or by using an implant with a proper geometry that could withstand this insertion torque, we could avoid this whole failure. And now when we came to the patient to restore what was what failed, it was a big problem because we did not have any more bone. So we had to restore the bone, we had to do vertical bone augmentation, and we did a vertical guided bone regeneration. I know, Omid, you're one of the pioneers in this. I've seen you working and doing a bone augmentation in Tehran, if you remember. We used PRF in order to give some boost for bone healing and soft tissue healing above this membrane. And look at the results. We went from a situation where we had no bone to a situation where we could recreate enough bone to place our implant. And now we have a very nice new regenerated bone. But what counts now is to be able to handle this bone very gently. Because you know that a newly regenerated bone is like a baby. You have to handle with a lot of care. You don't need to traumatize this bone. If you traumatize it, you will end up having bone remodeling or resorption or losing most of this bone. So we place these implants. You see the nice quality of bone that I have, and I adapted an implant. And as we said, this implant will not put any pressure over the bone because we are drilling and placing an implant that will only have stability through the threads. We had a very high insertion torque that was very stable for this case, and we decided to let it heal for 4 weeks, and we placed our crowns at 4 weeks. This was early loading in grafted bone, and look at the results 18 months later, the stability of the bone. So you see that when we adapt the proper geometry to the bone that we have, we can have accelerated protocols, and we can have long-term results. This is very important. Other cases, when we want to do immediate implant placement, extraction, immediate implant placement, it's very important to be able to have a good stability, because in these cases, you need to be able to load this implant immediately. This is a young girl. You cannot just place implant without having good stability. You cannot send this girl home without proper temporary. You don't want to place a removable temporary. You need to place the proper temporary in order to be able to guide the soft tissue healing. You can see here quickly the atraumatic extraction technique. It's very important because you don't need to destroy the bone around this implant. We extract the tooth, we place our implant, we drill again. This is a case that was done, as I said, we always drill to the same 3.3 millimeter. I use ultrasonic preparation also in these cases in order to have the proper placement of the implant. And this is the implant. You see, it's an implant with a core diameter that is exactly the same as the drill, and with very thin threads that will go and give us good stability, so we can predictably load this implant immediately, because this is what you need to do in cases like this. So you see the implant placement. Once we've done our implant placement, we know that we have enough stability. Then you see that my stability was above 45 Newton. I check my direction. It's very important to be in the prosthetic corridor if you want to do screwed retained prosthesis. This is very important because you don't want the screw to be in the buccal part of the implant. So the ideal implant placement is always very important. You see the ideal implant positioning, you're always towards the palatal. This is the radiograph. We have an implant now that is very long, very stable. We take the impression in order to do our, I'm still an old school guy. I do my impressions with impression material. I know that today everything is drifting towards intraoral scanner, and I should do the leap, but because I am a surgeon, I didn't do really the investment to get this scanner machine. And these are the temporaries that were prepared, placed for the implant, and you see how we have the soft tissue results after healing. We have a very nice soft tissue result because we could guide soft tissue, because we could place our temporaries immediately, because we use a predictable implant, and this is the result. Two final cases, we use this also for immediate implant placement and immediate loading. This is the situation where you need, even in extraction socket, to have good primary stability, good insertion torque, and we do the immediate loading in these cases, because when we adapt, and as you can see here in this radiograph, you see that this implant in the posterior maxilla, where I need to have good stability in soft bone, I use an implant with very deep threads, and this implant that was placed in the anterior maxilla where the bone was harder, I used an implant with small threads. So I could adapt. I could have an equilibrium between the hard bone and the soft bone, and instead of having 150 Newton centimeter here, I had 80, which is enough, and instead of having 15 Newton centimeter, let's say here, I had 40, which is enough for me to do predictably my immediate loading. And this is the final loading, and this is the radiographic results at the end. Even in cases like these, where we have enough bone to stabilize our implant, I reconstruct the bone, sinus lifting. For those who know me, they know that I'm very fond of sinus lifting technologies, techniques, sinus grafting. And now that I grafted the case, I need to place my implant, and I need to do my immediate loading and have enough stability in my grafted bone. And this is where the choice of implant is very important. This is where I need, in a grafted bone, to have an implant that can give me very good stability. And you see that implant here with very thin and deep threads because I need to have stability in the posterior maxilla with a surface that can give me a fast and dynamic healing. Very important. These are the keys to be able to do your early or your immediate loading protocol. So we place our implant, and you see in the posterior maxilla, we could place an implant with very thin thread. You see how these threads are giving me this good stability in the grafted bone. And again, in the sinus to the left, the same. You see how these very thin threads are going and grabbing the grafted bone. And you all know that the grafted bone is not usually from a very high. You could, with these implants, have a good stability impression. This is the standard protocol that we use, and immediate loading of these implants. And you see the bone around this implant, the perfect healing over time. And these were the final prostheses. And you see how these implants, this is a 1 year post-op panoramic X-ray. And please look at the anatomy of the geometry of these implants that were used in the posterior maxilla. If you compare with the implant in the lower, you see that all of these implants have the same thread shape. So if I put these implants in the upper, I'm sure that in areas where bone is good, I can have very good stability, but in area where bone is soft or so, I might have a problem stabilizing these implants. So this is why adapting the implant geometry to the bone density is very important if you want to predictably have high stability and do immediate loading protocol. So in conclusion, what should we expect from an implant? How can we plan the perfect loading protocol for our patient? We should expect to have an implant that is easy to place, easy implant site preparation technique. And this implant that I've been using, it's always the same preparation, 3.3 millimeter drill. An implant that can give us high insertion torque, but not without compressing the bone, and this is very important. And you see that the morphology, the geometry of the implant, the core diameter that is adapted to the implant site preparation, the knife thread was not over compressing the bone, so we did not have any loss of bone or stability around this implant. We need high and maintained primary stability. It's very important to maintain it over time, over the first 6 weeks. This is the key to be able to have ease of mind when you do immediate or early loading protocol. And it's very important to have a surface that gives you a very quick and dynamic healing over time. We've seen that with this surface, we could have as early as 4 weeks, we could see bone to implant contact. And with an implant geometry that is adapted to your bone, with a proper planning, yes, you can do a predictable early or immediate loading regardless of bone density. So that was it. I hope that I could answer your question about how we can predictably do our immediate loading protocol. I hope that I could give you the scientific rationale behind it, the clinical rationale behind it. And thank you, Omid, for inviting me and giving me the opportunity to be on your Hot Seat series. And it's always a pleasure.
Thank you so much, Christian. I have to say I enjoyed it. I enjoyed it as always. And I have to say it seems to be simple, but it's really a challenge for so many implant surgeons to decide when to load. And I have to say, so many people, even these days, are doing it like old-fashioned, waiting for 3 to 4 months to load the implant. And that's the reason these topics are very important to know, because by knowing the biology and how we can work with it, we can give our patient teeth in a very shorter period of time. So I have some questions, and we want to have a little discussion on this amazing topic, if I may. You talked about, you compared different site preparations at first, like drilling, pierce surgery, and osteotomes. And as you said, it was a great point that compacting the bone, crushing the bone may decrease the healing potential, at least in a short period of time. So I want to know now, what's your opinion talking about osteodensification with the drills? We go counterclockwise, we increase the density of the bone, and then we place our implants, especially in the size that we've done grafting, like sinus, like the cases that you showed in the posterior part of the mandible, that as you said, it's a new bone and we should take care of it. So comparing to those techniques, what's your idea, speaking of osseodensification? Do you find it, uh, you know, harming the bone comparing to osteotomes, or you find any difference about
To tell you the truth, I followed the publication about osseodensification. I've seen the histologic studies that were done by my friend Paolo Tricci, is one of the most renowned histologists and researchers in the field of bone, and I know that when he shows good results, they are really good results. At the beginning, I was afraid that this process can lead to bone damage or to bone necrosis, but it didn't. It didn't. The results were. Personally, I did not have any personal experience with these drills, so I'm not able to really give you the proper answer. I know, but I can only say that these drills there is an evidence base today that they are very good in condensing the bone and in giving a better environment for the implant. Now, how does this react with early loading, with immediate loading? It's only evidence-based that I can tell.
Mm-hmm, mm-hmm. And you talked about, you compared actually many designs of implant, and you said that that's what I got, that only with increasing the ISQ level, it doesn't mean that we reach the same success, and it depends on the implant design and geometry, because you presented, and it was a 2 implant in the posterior part of the maxilla, and you said it's a great implant, but with high insertion torque, you face resorption of the bone. So can we say that not only gaining enough ISQ means that it's good, and design of the implant should be included in our decision making? Is it right to say that?
Yes, this is a very important point, because as you're a clinician, I am a clinician, and we know that if you want to have a high insertion torque at day 0, you can always achieve this. You can make it, just squeeze the implant inside the bone and keep squeezing in and squeezing in until you reach a very high insertion torque. This can be done. This is not difficult to do. The problem is that when you do this, and if this is not part of the philosophy behind the geometry of this implant, this is why I said many times that I'm not saying at all that the implant that I showed are implants. They are very good implants from very good companies. I don't want to give names, but I can say that some companies' philosophy is to place the implant with very low insertion torque, because in their philosophy, they need to place the implant without harming the bone and leave the good implant surface to the bone in, and do then the loading at 6 weeks or earlier if their surface is very good. But in this case, they are only relying on a very good surface and on the measure of the design. Now, the second idea, and maybe this is what was very important in the particular design that I showed, that design could give us both things. It could give us very high insertion torque while respecting the bone and giving us the opportunity for that bone to heal very quickly over the implant with a very good surface. So yes, ISQ at day 0 may be very high, but what counts, as I said, is to be able to flatten the curve. We don't have to have a dip in the ISQ values. If you have an ISQ of 75 at day 0, you're very happy, and then you come back at 3 weeks and you see that your 75 is now 65 and you're in the danger zone. This is when you are in trouble, because then the micromotion of your implant is higher and the patient is eating on his teeth that you loaded immediately. And this is when trouble can start happening, because by having a lot of micromotion, we know, and these were in the first publication of Makler's years ago, that you need to have a very a low good healing and be able to have less failure rates around these implants. So the idea is to have a good stability at day 0, but the idea is to have a stable ISQ values over the time.
So I think we can say that we can say that, but by good design of implant, we can achieve high ISQ without compressing the bone? Because in the design that I noticed that you used, we are saving the bone between the threads instead of compressing the threads to the bone. And that's why, as you said, it's respect to the biology. So by saving the bone between the threads, we are increasing the mechanical stability without pressure. And so that's why we have highest ISQ value at the day one. And that's why we keep it, because we have bone locked down between the threads.
Exactly. Because you did not crash the bone between the threads, and you gave the bone the opportunity to heal very quickly. And this is why soon I wish that the results of the histologic study that we did. We did a human histologic study, and the results are really very interesting. We cannot yet show them because the statistics are not done, but you will see how bone is forming at 4 weeks and at 6 weeks, but what most importantly at 4 weeks around these threads. Because this bone was not disturbed, this bone was not damaged. You had a thread that was very thin that came into the bone without crashing it or compressing it.
Yeah.
And this is why, if you see when I showed the study comparing V thread to knives, you see that one stayed like this and one went down because of this bone remodeling process that we're talking about.
And Christian, one last point that I wanted to ask you, and you mentioned it, but I just want to have the correct sentences. Can we say that we can achieve high ISQ with low insertion torque with good design of implant? Is it the same or not? Because I think it's possible. We can place an implant with like 35 Newton centimeter insertion torque, but the ISQ gonna be 70 or more. So we have both things in our hand. Do you think it's correct?
Yes and no. I mean, there is always a controversy about the relationship between ISQ and insertion torque. I've done more than 4 or 5 publications on this topic, and in all of the studies that I had this correlation between both. But then you see other authors that show you studies where they have no correlation between insertion torque and ISQ. And since it's statistically proven, I'm sure that I'm right, and I'm sure that they are right. This is why there are other factors that can play a role, and this is geometry. Effectively, it is geometry. Some implant geometry can give you high ISQ with moderate insertion torque values. But when we talk about moderate insertion torque value, you cannot go very low. I mean, you cannot place an implant with 10 or 15 Newton and say that I want to, because even if 2 days later you want to adjust your prosthesis, the implant may turn if the insertion torque is very low. This is why you need, I said, at least 30 Newton centimeter. We did a study that we published in 2012 where we showed that all the implants below 30 Newton centimeter did not fail, but they couldn't withstand a 30 Newton early loading torque at 6 weeks, which means that there is a correlation between insertion torque and between osseointegration at 6 weeks. It's proven, it's evidence-based. There is a correlation between insertion torque and ISQ, but again, this is
on the design.
Also, there is a very important factor that is implant geometry that we take into consideration. It can affect, implant geometry can affect. The cortical bone can affect. There are a lot of variables that can affect ISQ, but you don't need to have 100 Newton centimeter to have 70 ISQ. You can have it at 30 or at 35 and it's enough.
Mm-hmm. Yeah. And you showed
the idea is to have, this is why I think optimal value.
Yeah. Yeah.
An optimal value of IT is a IT value that is not very high, but it's not very low. You don't need something very high to damage the bone or damage the component, and you don't need something very low to be in the danger zone. You need something optimal that is above 30, around 40, 50, 60 Newton.
Yeah, I agree with you. And my last point, you showed a case at the very beginning. It was, I think, an anterior mandible, and the bone was completely whitish, yellowish. It was like a D1 bone. So my question is this: Do you think that in D type of bone, the risk of failure of the implant gonna be higher, especially if we place our implant with a very high insertion torque because of the vascular supply. I know that in D1 type of bone we can gain great stability, but do you think the pressure in that type of bone, because we don't have good vascular supply, is higher? Do you think it's that way or no? I mean, comparing to D2.
Of course, I totally agree. Exactly. Now, look, the ideal bone situation, if you went bone with medium quality, between D2 and D3, where you have a bone that is good enough to stabilize, enough to be vascularized, so you need a very mineral bone. I would say that soft bone can be a risk factor, and hard can also be a risk factor. So you should recognize both risk factors. Mm-hmm. And this is why I said that it is as important to use an implant with the wide threads in soft bone to have good stability. It's as important to use an implant with very small threads in hard bone to try to reduce this insertion torque. And this is why when I compared some studies, if you see again in the lecture, I said that by adapting the geometry of the implant, we had a reduction in insertion torque in hard bone, because this is what we need to have. It's very dangerous in hard bone to manage the healing reaction if you over squeeze the bone or you place an implant with a very high insertion torque. This is why you see most implant companies, they add a countersink, they add a thread for the bone, a pad for the bone, because and they will always tell you, it's like a disclaimer for them, that if you are in hard bone, you should use this, because they know that in hard bone you will have a lot of problems. So yes, clinicians are happy to have very high insertion torque in hard bone to do immediate loading, but again, it's bad because over the first weeks it may induce resorption, and resorption may induce loss of stability. This is why you have to stay in the optimal values, which is the values good enough to allow you doing an early or immediate loading protocol, but not high enough to damage the bone or the implant components.
Exactly.
So this is the rationale. I mean, I try to give a scientific rationale in this lecture, because this is what counts if you want to take your decision. It's not out of luck. You cannot say, I will try my best to see if it works or it does not work. It will work if you follow the rules. And this was the idea that I tried to give in this lecture.
Exactly. And that's why I said at the beginning that I chose the best guy to present this data, because I told at the beginning, you open it up like no other, and you went exactly to the points that we wanted to hear on this exact topic. And I'm so thankful for that. So Christian, thank you again for your time. I know you're busy, you're tired now, but thank you for sharing with me, with all the audience on Hot Seat, and really, really looking forward to see you very soon, somewhere in the world, and hopefully very soon in Tehran, or maybe in Beirut.
Okay.
Yeah.
Thank you.
Hats off.
It's a pleasure. It's a pleasure. Both ways. It's a great pleasure.
Sure. Thank you.
Thank you. Bye-bye.
Take care. Bye-bye.